So it gives me great pleasure to introduce our first speaker today, Jill Clark, presenting a policy update from the Department of Public Health. Ms. Clark is currently the Director of the Division of Child and Adolescent Health and Reproductive Health at the Massachusetts Department of Public Health. She provides leadership and strategic direction for school, community, and clinical programs intended to provide better access to sexual and reproductive health, clinical services, education, and primary care for youth and adults, including PICCK. She received her Master's of Public Health degree in Global Reproductive Health from Emory University.
Thank you so much, Kate. And I am so delighted to be here this morning with all of you. Thank you so much for spending your Saturday with us. And I am delighted and have the great honor of being one of the folks that gets to work very closely with PICCK and the other organization that we fund to provide this technical assistance on contraceptive quality throughout the state. And I want to thank you, Kate, for having me here and for your really important words starting us off this morning. So as Kate mentioned, I'm going to talk a little bit about some policy changes, recent legal and policy changes that we have seen in place, what the implementation of those things has actually looked like on the ground, and some of the lessons that we've learned from these processes. So what's happened in the last couple of years in Massachusetts in sexual and reproductive health access and services? Oh, now I've gone too far. Okay, so, I see what's happening here, okay. All right, so first, I'm gonna talk about a couple of pieces of legislation and policy changes that have been important. Chapter 120 of the Acts of 2017 was known as the Access Act. This is the act relative to advancing contraceptive coverage and economic security in our state. And basically what this piece of legislation did was take some of the contraceptive access provisions of the Affordable Care Act and make sure that those things were included in Massachusetts law. So Massachusetts insurance carriers must provide all FDA-approved contraceptive methods with no copay. That has to include over-the-counter emergency contraception, and insurers are expected to dispense 12 months of contraception. This law was signed in 2017 and went into effect in May of 2018. Subsequent to that, we had a policy change that's important to PICCK and to many of you. Billing instructions from the Medicaid program were released, helping hospitals bill for the LARC device in the immediate postpartum period. And previously, hospitals would receive one global payment for labor and delivery and wouldn't be reimbursed separately for the LARC device, which in some cases can be very expensive. And so this billing guidance was issued to all acute inpatient hospitals, letting folks know how to be separately reimbursed for a LARC service when it was a LARC device when it was inserted in the immediate postpartum period. And this went into effect in early 2018 as well. Chapter 68 of the Acts of 2018 is also known as the PATCH Act, and which stands for an act to protect access to confidential health care. What this legislation was intended to do was address a confidentiality loophole that meant that people who were the subscriber on someone else's insurance plan might inadvertently have their confidentiality violated by the sending of what's known as an explanation of benefits to the primary subscriber. And so there were a number of changes in how explanation of benefits are handled under this law. Explanations of benefits are now to be sent directly to each patient, not to the subscriber on the main subscriber on the plan. And patients can choose how to receive their explanation of benefits, so they can, for example, not receive them in the mail at all, but receive them electronically. Explanations of benefits shouldn't be sent for preventive health services that don't have any cost sharing. So in other words, if there's no copay, then they just don't send the explanation of benefits at all. And explanations of benefits also will list more generic information for certain sensitive health services. So it might just say office visit, for example, if you went to get an abortion or a contraceptive implant. This was signed on March 2018 and went into effect in April of 2019. Chapter 155 of the Acts of 2018 has one of the most creative names of legislation that has passed recently. This was known as the Nasty Woman Act, which stands for the act negating archaic statutes targeting young women. I really love how they name some of these laws. And basically, there were a number of laws on the books in Massachusetts that criminalized various aspects of women's health care. These laws were not currently being enforced. They had been prevented from being enforced through various means, but this act removed all of these laws from the books to prevent them from being enforced in the future. This was signed in July of 2018 and went into effect immediately. So these have all been positive policy changes that we've seen over the last couple of years. Unfortunately, they have not all been positive policies. This policy changes to what's known as 42 CFR Part 59 Subpart A. That's a mouthful. But these are the implementing regulations that govern the Title X program. And we saw a number of changes to these implementing regulations. Some of the most salient are that they eliminated non-directive options counseling and required all pregnant people to be referred for prenatal care, even if they did not want to remain pregnant. They mandated the physical separation of abortion services so that abortion services could not happen under the same roof as other contraceptive services. It allowed Title X grantees to refuse to provide a broad range of contraceptive methods and removed requirements that those methods be medically approved. And in many cases, forced providers to violate the confidentiality of patients, and that was particularly true for minors. These rules went into effect in May of 2019 and were incredibly problematic for many folks providing sexual and reproductive health care under the Title X program. The Massachusetts Department of Public Health was incredibly grateful for state support that allowed us to continue to provide Title X services without interruption, without accessing the Title X funds, and therefore DPH and several other grantees withdrew from the Title X program in August of 2019. So what actually happens on the ground then, now that all of these laws and policies have been passed? So turning first to the impacts on contraceptive access, we've seen some positive changes here, definitely some increased access to contraceptive services for some folks. We continue to see the impact of contraceptive equity legislation in Massachusetts that requires all insurers to cover contraception. And many of the provisions of the Affordable Care Act have been well adopted in Massachusetts, including no copays for contraception. Most people are no longer paying copays for contraceptive services. We know that many providers are aware of changes that allow immediate postpartum LARC in hospitals and allow for the reimbursement of that service separate from the labor and delivery. And we're grateful that some of these unenforced but potentially problematic laws have now been repealed. But there are still challenges that we're facing. One particular challenge that we face is that dispensing of 12 months of contraception has been extremely variable. We have not seen adoption of that across the board in the way that we had hoped as a result of passing the access bill. And hospitals in many cases, and many of you are maybe very familiar with this, have struggled to actually correctly bill and really actually get the reimbursement they deserve for providing immediate postpartum LARC. And that is a significant focus of PICC's work. So how about young folks and what has been the impact on minors' access and particularly minors' confidentiality when they receive sexual and reproductive health services? I think in a lot of places, knowledge and awareness has improved. We and our partners have done a lot of work to promote the privacy provisions of the PATCH Act. And we have seen a pretty good uptake of the masking of sensitive services. So again, if you are going to access an abortion, an implantable contraception, or other sensitive services, generally speaking on the explanation of benefit, you will no longer see those services specifically called out, but they will be mentioned in much more general terms. And we're grateful that the new Title X requirements around parental engagement in contraceptive counseling for young people, even in situations where it may not be safe for that young person to engage their parents, have not had to have been implemented here in Massachusetts. But unfortunately, some of these protections still remain out of reach for many folks. The protections on explanation of benefits covered in the PATCH Act work very differently for people who are adults and people who are minors. For minors, the suppression of an explanation of benefits, in other words, if you don't want it sent at all because you're receiving a sensitive service, has to happen before each confidential service rather than being able to be done across the board, which makes it impractical or in many cases impossible. And although sensitive services are masked, the provider name is not masked on the explanation of benefits. So again, if you go to receive that abortion or that implantable contraception at a large national reproductive health service provider that it has a very well-known name, that name will still appear on the explanation of benefits, even though the specific service does not. And unfortunately, despite our best efforts, we are aware that, that awareness of the PACCK Act protections and how to implement those protections remains fairly low, particularly among patients. And then last but not least, thinking about access to abortion and pregnancy options counseling. Unfortunately, as we often see when it comes to abortion, the best we can do is hold the line. And so I think we have seen that there are new barriers to access that we have prevented from going into place. We have removed these potentially problematic laws from the books. We are grateful that Massachusetts providers can continue to offer comprehensive pregnancy options counseling. And it's especially important that contraceptive services and abortion services can continue to be offered by the same provider under the same roof, which is very consistent with quality care. We've made less progress in addressing existing barriers to abortion and pregnancy options counseling. The parental consent law in Massachusetts is still in place, meaning that minors need to get the consent of at least one of their parents or go through a difficult judicial bypass process. And it has been well documented that this process has a disproportionate impact on low-income youth and youth of color. And finally, we still see gaps in geographic access to abortion providers, which is the very predictable result of decades of laws that have been focused on over-regulating abortion providers and otherwise marginalizing abortion services. So given those successes and challenges, what have we learned and what can we do now to improve our successes in the future? So I would start by saying that the devil is in the details. The Department of Public Health is usually not involved in the policy development and advocacy stage, but we're incredibly grateful for our partners who do that policy development and advocacy work, and encourage them to involve many stakeholders in those processes, to work with others that have gone through that work or impacted by the potential policies, to solicit best practices and information, and to find ways to get input from the folks who will be at the implementation stage, and figure out how to create the policy in the way that can best be monitored and implemented. The Department of Public Health kind of comes back in once the law is passed and we get into the implementation stage. And it's critically important to follow up. It's not enough to change the policy or pass the law, but to really find out, is it working? Where is it working? How is it working? And if it isn't working, to know what buttons you can push to make it work a little bit better. And education is really important. Making sure that throughout the entire process, all stakeholders are aware that there's a need for a policy change and what the impact of any proposed policy change will be. And when we think about the impact of our policy changes, it's critically important to address equity all along the way. And these are just a couple of questions that I would suggest that it's important to ask anytime a proposed policy change is being considered, and think about who will be most impacted by this potential change in policy and who does not have a seat at the table when this policy is being developed. And true equity work is not just asking these questions, but also acting on the answers. So thinking about how will potential negative impacts be addressed, and particularly when potential negative impacts accrue disproportionately to low-income individuals, to people of color, to immigrants, and to youth. And also thinking about how the process for developing, implementing, and enforcing policies can be more inclusive, or in other words, how can we create more seats at the table? So there's always more coming down the pike. There are pieces of pending legislation that are in front of the legislature right now, including the Roe Act and the Health of You Act, Youth Act. The legislature is always continuing their work, and we will see where that process leads.
Thank you so much, Jill, for that great presentation. Our first question is a clarification on the masking of EOBs. Is that focused on both public and private insurance, or just public insurance?
We are fortunate that the law covers both public and private insurance. There are, however, some caveats there that, for example, it only covers Massachusetts insurers. And so if you work for, you or the primary subscriber on your insurance works for a large national company that purchases an insurance plan that is based in another state, that it would not necessarily be covered. There are also plans that are what's known as self-insured, which sometimes follow slightly different rules. And so Yes, it is both public and private plans, but there are some kind of idiosyncratic exceptions to that makes it very difficult for people to determine if their plan is covered. Sometimes the best thing to do is call.
Great. Our next question is about the 12-month dispensing of contraception. Could you talk about some barriers or challenges and even successes that you could share with other states who are trying to implement a similar change in their law to increase access?
Yeah, I think this is one where we have struggled a little bit and have not had as much success as we have like. The legislation is quite clear that 12 months of contraception should be covered. We've gotten a lot of pushback from insurance companies who say things like, you know, there's a lot of what's called churn in the insurance industry, people switching and changing insurance coverage and dropping off, and they're concerned about paying for a service that will go beyond the period of time that that person is actually covered by the insurance company. I think there's also challenges in making sure that prescriptions are written correctly. The sort of translation of information from the patient, you know, what the patient wants, to how the provider writes the description, to what the pharmacy interprets, to how the insurance company actually covers it, can be a game of telephone where things fall apart. And so I'm not sure I have good answers at this point, but we have continued to follow up with the Division of Insurance and to speak with individual insurance plans in Massachusetts to learn what their barriers are and try to figure out how we can implement more systematic changes that will make that 12 months of contraception actually achievable for more patients.